TRT is one of the most badly explained topics in men's health, especially on the internet. So apologies in advance, I'm probably going to burn 20 of your minutes up. And saying it's the worst online is saying something, because men's health online is like a casino where everyone is wearing lab coats. And I think most people hear TRT and start immediately thinking about injections. And that's honestly part of the problem. TRT is not one thing, it's a category. It could mean injections, it could mean topical, it could mean pellets. There's even other delivery methods outside of those. And in a broader testosterone optimization conversation, it could include things like HCG or clomiphene or maybe Clomid, depending upon what the patient actually needs. And the conversation has to start there. Shouldn't start with a vial, shouldn't start with a dose, shouldn't start with some dude online saying, bro, 200 milligrams a week, we're going to get your T-tote numbers to 1200. That's not medicine, okay? That's a Reddit thread with syringes. The first question needs to be, what is broken in the signal? Because testosterone is not just a number that floats around all by itself. Your brain talks to your testicles through your LH and FSH. LH tell the testicles to make testosterone. FSH is involved in sperm production. The testicles then respond. Testosterone goes up or down. Estrogen changes. SHBG changes how much free test is available. And then symptoms will change, which makes your labs change. And then fertility can change. This is one big system. So when a man has a low testosterone, the question is why? Why is the testicle not responding? Maybe it's the brain not sending enough signals. Is SHBG binding all of the free test up? Is free test low even when total T is normal? Is he obese? Is he not sleeping? Does he drink too much booze? Does he go to the gym too much? Is he taking medications that could be affecting the system? Does he want to have kids again or eventually? Does he even care about fertility? Is he 20? Is he 60? None of these are small details. These are literally the entire point. And this is where I would say 90% of clinics are lazy. They see low testosterone, immediately jump to injections. And sometimes injections are the right tool, but sometimes they're not, right? If a guy's testicles can still make testosterone, but the brain isn't sending enough signaling, something like clomiphene might make more sense. If fertility is part of the conversation, maybe we need to go with HCG. If he's actively trying to get his wife pregnant, you can't treat that person the same way that you treat a guy that's completely done having kids and just wants stable testosterone. And that's why TRT should not mean everybody gets the same shot and the same dose. That's assembly line retail medicine, and that's 95% of telemedicine clinics' business models. You go to the site, you tell them what you want, they make sure it won't kill you, and then they ship it. The problem is the male hormone system doesn't care what that your clinic wanted an easy protocol, right? So let's start with testosterone injections. It's going to be the most familiar one anybody listening to this is ever heard of, and they can work very well. They're blood direct, they're predictable, especially when they're dosed properly. They can be adjusted and compounded, and out of all of them, they're probably the most cost effective. But injections shut down natural production because you're providing testosterone from outside the body. So your brain's going to see the testosterone in the blood and be like, cool, we're not going to send any more signals because we don't need to make any, we got enough. So LH and FSH drop. The testicles slow down all of their own production, and sperm production can take a hit. That's why your testicles will shrink. And that's not a side effect in like the weird, like random sense. That's just the mechanism doing what the mechanism does. And that doesn't mean that every man on testosterone is sterile, okay? People love to speak in absolutes because if you speak with nuances, you actually have to use oxygen. Can testosterone suppress fertility? Yeah. Can sperm count drop? Yes. Can some men become azospermic, meaning no sperm at all in the semen? Yes. Should men actively trying to conceive be very careful with testosterone injections? Absolutely. But does testosterone automatically mean pregnancy is impossible? No. That's not true either. And we have helped lots of men get women pregnant while they were on testosterone injections. It can be done. It's done all the time. And the difference is you need to know what you're doing. You have to understand the axis. You need to understand how HCG functions. You need to understand sperm production. And you need to be willing to monitor on a higher level. And depending on the situation, we may need to do semen analysis. Maybe we're going to use HCG. Maybe it's enclomiphene. Maybe we're going to have to dose adjust, or maybe you have to go on a full fertility-focused plan. But it's not just keep blasting testosterone and hope your biology is going to be chill about it. Like, it's not a plan. It's basically a group project with no front man. HCG is important and works because it acts like an LH signal. And LH is the hormone that tells the Leydig cells in the testicles to make testosterone. So HCG can help keep the testicles active while you're on testosterone. And that's why HCG comes up in, fertility preservation and testicular function conversations. It's not because people like adding more medications. There's just a reason for it. If a man cares about fertility or their testicle size or keeping some internal production pathway support, HCG is going to be part of the discussion, but not always. It's not automatic, but it belongs in the conversation. Then you could talk about enclomiphene. So enclomiphene is a different kind of tool. It doesn't replace testosterone from the outside, so it's not synthetic. It stimulates the body to produce more of its own testosterone by changing the feedback signal at a brain level. So if the goal is to increase LH and FSH, which is what's going to increase natural testosterone production, while generally preserving all of your fertility signals, better than straight exogenous testosterone anyway. That's why enclomiphene is interesting for men who are younger, men with secondary hypogonadism, men who want to preserve fertility and aren't ready to shut down their own axis. It's not the same category as testosterone injections. It is not a weaker TRT. It's just a completely different lever. And then we could talk about Clomid next. So Clomid is clomiphene. It's a designer drug, basically. It's a mix of two isomers, enclomiphene and zooclomiphene. Enclomiphene is the isomer we generally want for men because it's directly tied to stimulating LH and FSH through an estrogen feedback pathway. Zooclomiphene is a longer acting one, and it has way more estrogenic baggage. And that's the part I personally don't like. People will casually say that Clomid is an estrogen blocker, but more accurately, it's a SERM, or a selective estrogen receptor modulator. It means it can block estrogen feedback in some tissues, but it can behave completely different in other tissue. So that's not the same as a aromatase inhibitor. It's not just, it's an estrogen blocker, it's good. That's oversimplification. And honestly, men's hormone care has enough, or already has enough people suffering from making estrogen basically a villain every time they talk about it. Men need estrogen. It's part of your libido. It's part of your mood. It lubricates your joints. It gives you erections. It's part of heart health and bone health. It's not trash. But too much can be a problem. Too much is also a problem. So the goal is not to just smash your estrogen because some dude on YouTube made some scary thumbnail about estrogen. But that's also why we prefer enclomiphene over Clomid when that pathway makes sense. So Clomid can work. I'm not saying it's useless, but Clomid gives you enclomiphene plus the other isomer that may not be doing exactly what you want it to. So if I can use the cleaner lever, why would I automatically choose the messier one? I wouldn't. I just don't like using extra hormone noise because it came bundled in the medication. Next, let's talk about dose. Honestly, this is where things get really stupid really fast. The number of men who get started out at 200 milligrams a test right out of the gate is insane. It's not a conservative starting point. That's honestly the high end of what most weekly TRT protocols even use, and some medical boards will get angry at you if you prescribe too many people at or above that amount. So starting there without understanding the patient at all or how its body is going to react, how SHBG and free test are going to balance aromatase enzymes and estradiol response, hematocrit, blood pressure. It's just lazy, right? More is not better. More can also mean more side effects. Higher hematocrit, way more estrogen conversion. Maybe you'll get acne or blood pressure problems. Maybe you start getting more road rage or more sleep apnea. It could be, why do I feel worse even though my total T numbers are higher? Because that number is not the patient. The goal of TRT is not how far or how high we can push a lab without you catching fire. The goal is symptom improvement, right? You want physiological levels to change safely, stability, something that you can live on. A lot of men do much better starting lower and doing some monitoring and then doing some adjusting. That's basically how adult medicine works. You don't start at a ceiling and then act surprised when we do your labs and it looks like a police report. And that goes the same for injection frequency. One huge shot every week can create a peak and valley. Some men feel great doing that. Other people crash before the next dose. Sometimes more frequent dosing can smooth things out for some patients. That doesn't mean that everyone needs the same schedule. It is not one size fits all. All it means is that the schedule matters, right? The dose matters. Your SHBG matters. The way that your body responds matters. And the patient and their symptom matters. It's also why lab monitoring isn't optional. You can't manage your TRT off of the vibes that you have when you're in the gym. You need total T. You need free T. You need SHBG and estradiol. You need CBC and hematocrit, PSA. Blood pressure, lipids, CMP. We need to talk about your sleep and other symptoms, fertility goals, whatever side effects you have, like the whole picture. Otherwise, you're just guessing with a controlled substance. And speaking of controlled substance, let's talk about the FDA warning label. Because a lot of people's opinion on testosterone got stuck in 2014 and they never did a software update. So for years, testosterone carried a huge fear around the heart attacks, strokes, other cardiovascular events. And the way I got talked about made it sound like the minute you started TRT, your heart was going to kick down your front door and evict you, right? So to be very clear, testosterone is not something to be casual with, right? It's a real medication. It can affect your red blood cells. It can affect your blood pressure. It will affect estrogen. It will affect fertility and sleep apnea, right? It can even affect like how you feel just mentally, right? So them removing the black box is not, testosterone has no risks, but the old like heart attack and stroke fear stuff was way too broad. However, I think a lot of men heard TRT causes heart attacks. I would say a lot of oncologists and stuff like that, and other doctors heard, don't touch testosterone unless you want legal liability problems. And I think a lot of men with real symptoms, repeated low labs and actual hypogonadism got dismissed because the warning label scared everyone from wanting to have a real conversation about it. So that's why this warning change actually matters, right? Because warning labels shape behavior. It's like marketing. Patients see them and get freaked out. Providers see them and get conservative. Insurance companies see them and get annoying, which, to be fair, is really their natural resting state. So for years, the bumper sticker version was TRT is bad for your heart. And like most bumper sticker medication, it was missing most of the picture. So in 2025, the FDA changed the labeling for testosterone products after reviewing a trial called Traverse, and they required blood pressure studies. But the big part is the FDA removed the black box warning language related to the increased risk of major adverse cardiovascular outcomes for testosterone products. So if you don't know, a box warning is the strongest warning the FDA can put on a drug label. So them removing it is not like a clerical update or someone at the FDA like just pulling a sentence off. It literally means that the older broad warning didn't match the evidence that they now have for men being treated appropriately for hypogonadism. And the Traverse trial matters a lot because it studied the exact type of people that everyone was worried about. It wasn't like a 23-year-old with abs and ring lights and affiliate codes and influencers. These were hypogonadism like positive men who either already had a cardiovascular disease or were at high risk for it. So older men, guys with low T, lots of symptoms, and like real cardiovascular risk. So the study compared T therapy to placebo and then related them to cardiovascular events like cardiovascular death, non-fatal heart attack, non-fatal strokes. And over the course of it, they found that the therapy didn't have a higher rate of those major cardiovascular events compared to the guys that took the placebo. So that's what the research pushed back on. It didn't prove that testosterone is going to prevent a heart attack. And it didn't prove that it's cardioprotective either. And it didn't say that you could just blast testosterone because it's safe, right? It doesn't apply to every super random guy taking a super physiologic dose because he wants his traps to be shaped like a fridge. It debunked the broad fear that properly prescribed TRT for men with real hypogonadism automatically increases heart risks. That's a big difference. And that difference is a big deal because men were being scared away from treatment that would have benefited them. But the FDA did not just remove a warning label and say, like, have fun with this, boys. They required blood pressure information to be added to the labeling. Testosterone can increase your blood pressure, so that's still real. So the updated message that they're saying is not TRT is dangerous, but it's also not, TRT is completely harmless. The updated version is the old warning that we gave you came down because newer evidence doesn't support that fear in the properly selected men, but TRT still needs to be monitored because of blood pressure and other safety markers that matter. So while that's the real version, it's obviously less dramatic and more useful medically, but it's somehow harder for the internet because you can't scream that it's safe in like all caps. This is the same reason that lab monitoring a lot of markers is very important. We should reduce outdated fear because of the removal, but it shouldn't take away responsibility. You still need to be checking all of the markers. Your hematocrit matters. Your estradiol matters. You should still do prostate, screening when it's appropriate. Dosing is important, and overall, the patient and how they feel matters. So the warning changed, but the need to be competent didn't. And I think that's the part that people need to understand. So, and TRT done correctly is not the same thing as steroid abuse. It's not the same thing as just blasting 1,000 milligrams. And it's not the same thing as starting every man at the top end of a weekly range and, hoping everything shakes out. Real TRT means diagnosis, proper labs with proper markers. You can't get away with just total T. It means nothing without the rest. You need monitoring and adjusting, and I think the broad TRT conversation should kind of look like this, right? First, you need to confirm the diagnosis. What is it? Symptoms matter, but labs matter too. We're not treating labs, we're treating symptoms. So one random afternoon testosterone level check is not going to be enough. We need to do labs in the morning while you're fasted. We're going to need to do them pretty often. And then we need to figure out the type of problem. Is it primary or secondary? Because they're not the same thing. If LH and FSH are high and T is low, that gives us one story. If LH and FSH are low or inappropriately normal with low testosterone, gives us another direction, right? Third, find the right lever. If the man needs a replacement, testosterone may make sense. If he can still produce and you want to stimulate the system, maybe enclomiphene makes sense. If fertility or testicular function is important, maybe it's HCG. If someone's already on testosterone and wants, to have a pregnancy, the plan might need to change, but it doesn't make pregnancy automatically impossible. Fourth, don't dose like an idiot. If you're working somewhere that everyone's at 200 milligrams and you're not getting compounded personalized medicine, they're taking a shortcut. The protocol needs to be built around you, not the provider's favorite number of what's easiest to script as fast as possible 100 times a day. Fifth is monitor. Between TRT done well and badly, it's not one that uses testosterone and one that does not. It's about evaluating dosing. It's about educating. It's about following up and adjusting. TRT can be absolutely life-changing for the right person. You can get your energy back, you get your libido back, you save your marriage, your mood's good, you'll be more motivated to go to the gym, strength, body confidence. Not the fake stuff, the stuff that you feel when your body's not running on airplane mode anymore. But it has to be done right. It's not just a shot, it's not just a total T number, it's not just inject, it's a system. So all of this stuff, testosterone injections, HCG and clomiphene, Clomid, topical options, fertility goals, the monitoring and dose strategy, side effect management, and all of the risks need to live in the same conversation at the same time. That's what makes TRT real medicine instead of some gym bro subscription box. So the right question is not how much testosterone do you give? The right question is, what are we trying to fix? Which lever makes the most sense? How do we keep the patient healthy while we do it? And that's the conversation that TRT people should be having.